This is my conflict of interest disclosure. Well, this is the history of bronchoscopy. A lot of innovation, a lot of new technology, but just few changed really the way to perform bronchoscopy. And I put in yellow the main step of the history of bronchoscopy that are the advent of flexible bronchoscopy, the advent of flexible TBNA by Kopp and Bang, and what really changed our way to perform bronchoscopy is the introduction of EBUS-TBNA in 2004. These are the pioneers. Mark, you are here, the first paper. Probably you have another one on 2003 that you showed us. Kazu from Canada and Felix Sert published the first paper on EBUS-TBNA. And they demonstrated that the sensitivity was very high, regardless the lymph node location or size, and the specificity was 100%. For this reason, very soon, the EBUS-TBNA became the first step in the staging of lung cancer in all the guidelines published about the pathway, diagnostic and staging for lung cancer. Well, lymph node staging and diagnosis was the first application of EBUS-TBNA. But in the following years, we realized that with linear EBUS, it was possible also to have other indication, to diagnose pulmonary lesion adjacent to the large airway, to diagnose peripheral pulmonary lesions, to diagnose pleural lesion adjacent to the mediastinal. We learned to go through the esophagus, and this was really a great advantage for the pulmonologists. The esophagus is a highway into the thorax. And so to learn to go through the esophagus with the EBUS-scope is a great advantage in our diagnostic technique. We were able also to evaluate endovascular lesion and to make differential diagnosis between sarcoma and embolism. Well, my presentation shows you some clinical practical cases of all these applications of EBUS-TBNA. We start with central endobronchial pulmonary lesion close to the large airway. You can see here there is a lesion close to the trachea. If you put your EBUS-scope in the trachea, you can visualize very well this pulmonary lesion, and it's very easy to take sample with the EBUS-TBNA and to make diagnosis. It was a squamous cell carcinoma. Going into periphery, we have a small lesion adjacent to the right main bronchus. Again, it's very easy to put your echo-bronchoscope on the orifice of the right main bronchus and look at. You can visualize the lesion very well, and it was very easy to take a sample of this pulmonary lesion and to get diagnosis of adenocarcinoma. Go on, more in the periphery. This is another lesion close to the right main bronchus. Look at, it's easy to visualize it with echo-bronchoscope, and the diagnosis is hamartoma. More in the periphery. This is a lesion at the orifice of the left upper lobe bronchus. Just put your echo-bronchoscope here, and you can see the pulmonary artery here, and it's very easy to visualize and to sample the lesion. It was an adenocarcinoma, but we can go more peripherally. You know that it's possible to introduce your echo-bronchoscope in the middle lobe. There is a lesion of the middle lobe. You can introduce your echo-bronchoscope, and I'm talking about normal size echo-bronchoscope, not the small one. But with the normal size echo-bronchoscope, you can go to the middle lobe and look at. Very easy to visualize the lesion. And this is the demonstration that the echo-bronchoscope is just inside in the middle lobe. And this is another lesion of the lateral segment of the middle lobe. It's possible, even in this case, to push, to wedge your echo-bronchoscope and to visualize this lesion. Look at, and here is your echo-bronchoscope into the middle lobe and the needle just into the lesion. Very easy diagnosis to perform under direct visualization. Adenocarcinoma, this is the sampling. Well, if the lesion is not in contact with the airways, you know that Galileo Galilei says, yet it moves. And it referred to the earth that was moving. But also the trachea can be moved into the mediastinum. And if we have a lesion that is not close in contact, we have a more than 1 centimeter distance, we can push, we can bend the tip of the scope, we can bend the trachea, and we can visualize the lesion. Even if the lesion is not in close contact with the airways, please try. Bend the airways and try to take a sample. You can see here the movie of the sampling. And here is the needle. And the trachea that is bended. Well, and for the peripheral lesion, don't forget that the tip of the echo-bronchoscope is 3 millimeters large. So you can wedge the tip of your echo-bronchoscope in the periphery of the lower lobe. It's not possible such kind of approach for the upper lobe because it's very difficult to push the echo-bronchoscope in the upper lobe. But it's very easy to push in the lower lobe. Look at, there is a bronchus here. It's 5 millimeters. It's possible to wedge the tip of your bronchoscope here and to visualize this nodule. Very safe and very easy diagnosis of carcinoid. But look at this. This is 8 millimeter nodules in the right lower lobe. If you have a patient that will come in your hospital tomorrow with such a lesion, try to think what I would do for such a lesion, 8 millimeter. But tomorrow, after my presentation, you can look around and there is a bronchus. There is a bronchus that is 5 millimeters, so I can wedge my echo-bronchoscope in this bronchus. I can bend a little bit my echo-bronchoscope, and what happens? This is the magic visualization of this 8 millimeter nodule in the periphery of the right lower lobe. And it's very easy to take a biopsy. Look at, this is the needle. And the diagnosis was metastasis of urothelial cancer. 10 minutes of procedures. No need of fluoroscopy, no need of robotic bronchoscopy, no need of further technology. just EBUS-TBNA. Again, this is another small nodule. There is a large pulmonary artery branch, very close. This is the nodule, this is the artery. You can take a sample very easily and safely. Is again 1 centimeter nodule in the right lower lobe, very peripheral. Here is the diaphragm. On the left side is the same. This is a peripheral nodule. Look at the bronchus. No problem to put your echo-bronchoscope to visualize the lesion that was a carcinoid. And again, a very small nodule in the left lower lobe. Here is your echo-bronchoscope. Here is the nodule, the sampling. This was unfortunately not a carcinoid, but it was an adenocarcinoma. Smaller nodule, but there is a bronchus. So try every time that you have a nodule in the lower lobe, try your approach with EBUS-TBNA. It was a metastasis of melanoma. And look at, this is a nodule with a lot of bulle, high risk for percutaneous needle aspiration. But if you put your echo-bronchoscope, you can arrive at this level, you can visualize the lesion, no risk of pneumothorax, and diagnosis of non-small cell lung cancer. Well, this is a lesion very close to the diaphragm. Is it possible to introduce your echo-bronchoscope at this level? Yes, look at. Is it possible? You can visualize the lesion and sampling, but look at this. This is a lesion in contact with the pericardium. And you can see the pericardium sliding. There is the sliding of pericardium through your echo-bronchoscope. And the diagnosis was a metastasis of breast cancer in this woman. We published the results in this paper. The first 30 patients with a small pulmonary nodule, less than 3 centimeters, in the lower lobe. And you can see that the diagnostic yield was 92.8%. That for nodule less than 3 centimeters is a value greater than with any other technological tools. You can use robot, you can use combined CT, you can use electromagnetic navigation, but you will never reach 92% of sensitivity that you can get with EBUS-TBNA. The esophagus is a super highway through the thorax and is a new way, and every interventional pulmonologist should use it, should move your echo-bronchoscope through the esophagus, because you can sample a lot of lymph node station not in contact with the airways, but you can also sample paraesophageal lung lesion, paraesophageal pleural lesion, liver metastasis, and the left adrenal gland metastasis. This is a pulmonary lesion. Here is the esophagus. As the trachea, the esophagus is moving into the thorax. So you can bend the esophagus with your scope, and you can put the esophagus close in contact with the lesion that is very well visualized. And again, here is the lesion, here is the esophagus. Put the esophagus on the left side with bending your echo-bronchoscope, and you will visualize very well the lesion. And this is a mass that is in contact with the esophagus, and it's very easy to perform such a bioptic approach. This is a pleural thickening. This is the esophagus. It's no problem to visualize this lesion that involved the pleural, that involved the right upper lobe. It was lung cancer. And look at this. This was a patient that 2 years before underwent upper lobe lobectomy for adenocarcinoma. After 2 years, this small thickening of the pleura was visualized on CT, and it was PET positive. How to approach this pleural thickening? There is the esophagus, very close in contact with this lesion. And look, this is our echo-bronchoscope into the esophagus. You know that the acronym of this technique is EBUS-TBNA with a B. That means with the bronchoscope. Sorry. You can visualize the pleural thickening that unfortunately was a metastasis of adenocarcinoma. Well, pleural mass. This is the echographic view through the esophagus, intensity positive on PET. And you can see the sampling of this pleural lesion that was a mesothelioma in this case. Left adrenal gland. This is the normal appearance of the left adrenal glands, like a bird, with your echoscope. And when you have a metastasis, this aspect disappeared. And this is the aspect of a left adrenal gland metastasis through your echo-bronchoscope. So you can stage lung cancer also for the M parameter. What about the diagnosis of endovascular lesion? There are a lot of papers in the literature that report the differential diagnosis of sarcoma versus pulmonary embolism using EBUS-TBNA. Well, this is a pulmonary embolism. You can see here the embolus, very well visualized with the echo-bronchoscopy. And this is the embolus. And this is a very nice case of a neoplastic embolus. Neoplastic embolus into the pulmonary artery. You can see here this endovascular involvement very close to the tumor. Well, somebody can ask, oh yeah, but you can diagnose pulmonary lesion, but what about the quality of the sample? What about the adequacy of the sample for the genotyping or for molecular evaluation? There are a lot of papers in the literature that report that EBUS-TBNA sampling are able to provide material adequate for genotyping the tumor. Just the best way to treat the sample is to put together smeared cytology with core biopsy or cell block. And you can see the amount of material that is possible to get with a needle. Our pathologists are very happy because there is a lot of tissue, and all the next generation sequences or the evaluation of PD-L1 is possible on EBUS sampling. Well, in conclusion, EBUS-TBNA changed our diagnostic approach, greatly increasing the sampling possibility of bronchoscopy. Is today an irreplaceable means for lung cancer staging, for diagnosis of hilar mediastinal lymphoadenopathies, but it is also a very precious instrument for diagnosis of several pathological conditions involving not only lymph nodes, but also other structure close to the airways and to the esophagus. Correct management of samples is, of course, a necessary requirement to optimize results. So we have to say thanks to the pioneer that introduces this technology. Thank you, Mark. Thank you, Felix. I don't know if he is still here, but you changed really the way and the possibility to performing everywhere in the world. Thank you very much. This is the hospital in Milan where I'm now working. Thank you.